Watch the red eye.
Yeah, I had a close friend run in it.
Oh, nice. They have beautiful weather this year, which is really nice. And no mass casualty deaths, so that's always a plus, right?
Well, definitely on the safer side.
Oh, really? Yeah. We usually every so often have a student volunteer medical time. All right, I'm going to be recording this. All right, so this morning we are carrying on with the topic that we have covered that you talked about, most likely from fundamentals, right, where you learn about the Bible science. And then last semester we discussed hypertension as a pathophysiology and how it contributes to so many other significant diseases that can potentially affect your lifespan, right? So hypertension is directly related to risk of stroke, or heart attack, and for kidney disease, right? So it all kind of ties together. This last hour, I'll just really quick an hour, is about a very small portion of patients that come in with what we call a hypertensive crisis. Okay, that is an umbrella term, and there are two disorders underneath that. So we're going to look at that specifically for today. How many of you have had a patient with a admitting diagnosis of hypertensive urgency or emergency? Okay, I definitely have seen them. And although it is a fairly small proportion, it's considered critical that these patients be seen immediately and that their blood pressure be addressed. Now, there are those patients that come in with sky-high blood pressures that might fit under this category, but it's for a reason. Let's say I think about my patient with the fish hook sticking out of his femur muscle, right? So you're going to take that fish hook out, and the blood pressure is going to come down. You're going to treat the pain, the pressure is going to come down. But this is a patient that looks otherwise fairly healthy. They might be really young, they might be middle-aged or older, but they have this situation where their blood pressure is through the roof. Okay? So we'll talk about how we assess these patients. Let's first look at our student learning outcomes. All right, so once again, we have safety, most very important. So we're going to identify key considerations when managing a patient with a hypertensive crisis, including proper medication administration and monitoring for adverse reactions. Okay? So to those medications, these meds act quickly and they can potentially harm the patient by ways. Demonstrate the ability to monitor vital signs, so always accurate signs, interpret data and patients experiencing a crisis to prevent complications such as organ damage or stroke. So that's what we're trying to do. It might be, they're already having signs of organ damage or stroke, but they're definitely at risk. Apply protocols for patient safety, ensuring the safe and accurate measurement of blood pressure, and minimize the risk of med errors during crisis management. So these are oftentimes stressful times for the patient, and they may not feel well, they might be symptom-free, but often there's an anxiety component along with this. Anxiety might be driving their blood pressure as well. Family might be very concerned about these patients, and they want to see that blood pressure come down. So have you ever noticed them just staring at your screen? If you have a monitor in the room, or just, they're really concerned when they see that blood pressure come down. Patient-centered care, always. We consider the comorbidities, the patient preferences, cultural factors to provide this. Evaluate their needs. They're going to have a lot of education needs most likely, because if they aren't on an antihypertensive, most likely they're going to be on one. So always teaching about that. And then always going back to lifestyle modification and medication adherence, because we know that more than 50% of people who go on blood pressure medication are going to stop it in that first year. So we're always addressing the importance of compliance and follow-up. Professionalism will always always collaborating with healthcare teams, ensuring accurate and timely information exchange regarding crisis intervention. If you have a blood pressure that's really, really high, you're going to communicate that, right? You're not going to wait on it. You're going to first assess if there's anything else going on with that patient, such as pain or something that's causing it to be high. But you're going to be making sure it's accurate, making sure your patient's not talking, or being a talker. So start listening first, at least 5 minutes, right? You have one not talk. Make sure all the things that make for an accurate pressure. The cuff size is correct. All of those things we talked about last semester. And we're going to report it. Okay, so if you've got a really high pressure, you're going to make sure that gets communicated, and you're fully assessing the patient for signs of target organ damage related to hypertension. Okay. Are they having signs of stroke? Are they having chest pain? We're looking at their kidney labs, right? That's becoming insult to their kidney, urine output. Evidence-based practice, we started off that last semester talking about all of the different studies on how the American College of Cardiology and all these different organizations came together and reviewed hundreds of evidence-based research articles and then developed the JNC 8 latest guidelines for hypertension management. Okay? And then came up with all of the algorithms that we follow for hypertension. So we are going to look at specifically the algorithm for hypertensive patients today. All right, so we're going to start with our patient. There's a picture of them on the very first slide. But we have this 51-year-old male that presents to your emergency department with a 3-day history of this headache, severe headache that just won't go away. It's been unrelieved with Excedrin and with Motrin, and you are going to ask questions about how much they took, when did they last take it, and you're going to make sure there's nothing else that they took in addition to that. Okay, maybe they took their wife's lorazepam or something. So you're going to find out have you taken anything else. We're visually looking at this patient, assessing them. We notice that they have a high BMI of 37.3. So they are overweight with an abnormal distribution of weight around the abdomen. They are reporting that they're not very active, that they're sedentary, except for their job is fairly active as a part of it. They does not like to cook, wife doesn't like to cook, they eat out 3 to 5 times a week. So we know there's probably a pretty strong incident risk, there's a pretty strong possibility that they're getting quite a bit of sodium in their diet if they're eating out that many times a week. And most likely it's fast food, which isn't the most nutrient-dense food. Also a smoker, 1 pack per day since the age of 20, so that makes it 31 pack year history. Has a history of hyperlipidemia, so the total cholesterol is elevated. We're going to be looking at his labs in a little bit, but could not afford his statin, his atorvastatin, so he has never started it and hasn't had follow-up. That was 5 years ago. So you can imagine this may have worsened over 5 years, but there's been no change in lifestyle. No current diagnosed medical problems. He's been fairly healthy. Comes in also because he's more easily fatigued, and then this headache that just won't go away. They're very concerned about it. We're actually in the ED net urgent care. And his wife shares to the nurse, close to the nurse's side, to the nurse, and says, this my husband's usually really stoic, this isn't like him to complain about any health concerns, and she's just really concerned about him. All right, so given vitals, that's one of the first things we're doing besides definition. While we're interviewing them, we're probably doing the vitals at the same time. And we find that the patient has a temp of 98.9, a pulse of 108, and it's regular. When you palpated, respiration of 20. We check the blood pressure, and it's 230 over 128. Okay? So what's the next thing you're going to do? We notice the stat is 95% per minute. What's the next thing we're going to do? Are we going to recheck this?
Yeah.
And if it's a diamond, I'm just pulling in the name up top, and I want to hear it. Might be uncomfortable pumping that cuff up that high, and we might be voice that to you. We're also, so we're making sure we have the right size cuff for this guy too. Probably might be using a large cuff. And we have them, not to acknowledge and guide the performance of this. And then we're going to assess for pain. So we know that they complain of a headache coming in. So he is reporting this as a throbbing headache. It's global, so it's kind of this whole head, and it's about an 8 out of 10, and it's been continuous. It just hasn't gone away. All right, so if we look at our GMC categories for hypertension for adults age 18 and over, we notice that he falls way down here, right? So he's under the hypertensive crisis. His systolic is higher than 180, and his diastolic is higher than 120. Okay? So that puts him in this hypertensive crisis umbrella. So then we're going to know that we have two types of hypertensive crisis. We have hypertensive emergency and hypertensive urgency. Okay? So we follow the category, and what differentiates hypertensive emergency from urgency is not the blood pressure. Most people think, well, it's got to be the higher blood pressure that makes this an emergency, but it's not. It's actually whether they are having symptoms of target organ damage, or perhaps a lab result or a diagnostic test result that places them in this category. So let's say you do a some labs will do an EKG and there's some signs of ischemia to the heart muscle, okay? That would put them in the emergency category because there's a sign of an organ damage to the heart, okay? You get the labs back and you see their kidney failure, maybe some creatinine and there's an aerobic filtration rate. They are then placed in that category of the emergency, okay? Or they have signs of a stroke. They develop slurred speech, right-sided weakness, anything that puts them in that category. So that, obviously, that person's being rushed to CAT scan for a head CT to rule out ischemic versus hemorrhagic stroke. So, if they are not having any of those signs, they go into this category of hypertensive urgency. Okay? So, they are treated differently. And in the situation with the emergency, we are working quickly to try to get that blood pressure down, okay? Using intravenous vasoactive medications, okay? And there are situations where we don't want to bring it down quickly, which we kind of mentioned that last semester. Those are listed right here. If somebody has an aortic dissection, or if somebody has severe preeclampsia or eclampsia, we can rule that out for this gentleman. Or if somebody has a pheochromocytoma crisis, remember what that is from endocrine? What is a pheochromocytoma?
A tumor on the adrenal glands.
It's a benign tumor that secretes catecholamines. Right? So it's the one form of hypertension that's cured with surgery, right? So you got to remove that too.
And that was all for emergency?
Pardon?
That was all for emergency?
Yes, yes. So those are conditions that you would want to very, very, very quickly get the blood pressure down. And that has to do pretty much with the aortic dissection. Having a really high pressure can worsen the dissection, and that's why you want to get that pressure down much more quickly. So, under hypertensive emergency, we're going to reduce the systolic to less than 140 millimeters of mercury during the first hour, and to less than 120 millimeters of mercury in aortic dissection. Okay? You don't have to memorize that. Just know that you want to get it down much more quickly for these conditions. If those aren't present, we would want to reduce the blood pressure by a maximum of 25% over the first hour, and then to 160 over 100, 110 over the next 2 to 6 hours, and then to normal over the next 48 hours. So we're bringing it down 25% in the first 2 to 6 hours, and then more slowly over the 48 hours. So this is hard for patients to see. They want to know, why aren't we getting this pressure down right now? Or the family, and I've had family members like, we gotta get that pressure down, and we have to just inform them that the best practice shows that we gradually bring it down. It's better for the patient. Okay? So Brian, that you're looking at and treating in the emergency department, doesn't have any of these going on. He doesn't have any signs of organ damage that you see. He's going to fall under this hypertensive urgency category. Okay? So, once again, it's not the blood pressure that makes it emergent or urgent. It is the signs of target organ damage. It doesn't hurt too much. So, the difference here is that we're going to reinstitute or intensify. So, if they're already in and they have this and they're on meds, we're reinstituting or intensifying oral antihypertensive drug therapy and arrange for follow-up. So these patients can still have a really high blood pressure, and there's a chance they could end up moving over to this category. So you're watching for that all the time. Right?
So with urgency, you give them oral, and with emergency, it's IV.
IV.
And if it's the 3 conditions, it's quickly. If
Yes.
it's not, then it's slowly.
Very good.
Okay.
All right, so let's look at his assessment. All right, he appears uncomfortable. You mentioned he's anxious, his body's tense. He's grimacing because of that headache. His breath sounds are clear with equal aeration by lather, so negative, benign respiratory assessment. There is some changes with his cardiac assessment. He is inflammatory, doesn't have any edema, his heart sounds irregular. He has bounding pulses, okay? So when I'm calculating the pulses, I just noticed they're very, very full. But they're equal, so there's no irregular rhythm, and we're calculating at the radial, the kilo, and the studio nanomass. Neuro, this is important, so really good, a quick neuro assessment to make sure they're not having any changes that could indicate stroke, right? So this person who's alert and oriented, the person who's in time in the situation, can tell you what is there. No issues, neuro nothing. GI, tender, bowel sounds audible, and also he's worried about difficulty, urine clarity, heavy urine sample, skin integrity is intact, and there's no tenting, so he's not dehydrated. And then we send off the labs, and we're going to get his labs back. All right. So we're looking at his basic metabolic panel. This is a standard test that's done just about on everybody that comes in the ED. And it gives us a really idea of just the patient's, always gives you information about relevance for your patient. So we noticed the sodium is okay. It's 136, so 135 to 145 is normal. How's the potassium?
Fine.
It's right in the normal, 35 to 45. Glucose is 188, it's a little bit high. Maybe we don't know that. Creatinine is at 1.5. Okay. So for a male that is a little bit elevated, the creatinine is really important, like I mentioned, because we really can't say, unless we look at labs and possibly, urine output would give you a little idea. But the lab is really important. The eGFR is also important. So if this patient is having some kidney insult, we're going to see it in an elevated creatinine level. So that is important. The CBC is always been normal, so you don't have to worry about anything there. What do you notice about the cardiac labs? Okay, so the BNP. You're going to tell me what a BNP is significant for.
Heart failure.
Very good. Okay. So when the heart muscle gets overstretched, okay. So let's say there's if you have hypertension, and that's obviously increased pressures within the arteries, and if the heart's having to pump against increased pressure after load, we call that afterload, that left ventricle becomes overstretched and overworked, and it releases this brain natriuretic peptide. Okay? So the higher the level, the more significant that is. So less than 100 would be normal. So he's significantly high. So this tells you right away that he is having some changes related to his hypertension. Okay? And I would want a chest X-ray pretty quickly as well, right? And you're getting that because you're ruling out aortic dissection. This guy's probably going to be going for a chest CT, all these other things as well. All right, so that's the plan. LDL is 260. What's the normal LDL?
100.
And what does LDL stand for?
Lousy.
Low density lipoprotein, right? So that's our bad cholesterol. So we want that less than 100. We remember he told us 5 years ago he was elevated. He was supposed to go on a statin. He did not. And now he's at 260. What does the HDL stand for? High density lipoprotein. Do we want that high or low? We want a high HDL. What increases our HDL?
Good fats.
So, exercise and fish oil, things like fish oils will increase our HDL. Okay? Total cholesterol is 290, okay? So that's elevated. And then triglycerides are also elevated at 484. We get the chest X-ray back. They come into a portable chest film. This cardiac size is enlarged. There's no focal infiltrates in his lung or consolidation, so there's no pulmonary pathology going on. No acute disease in the chest. Moderate to severe cardiomegaly. What's cardiomegaly? So the heart's enlarged. And why is it enlarged? Because of that blood pressure, right? So the heart's going to pump against increased afterload and resistance in the vessels. So that left ventricle is enlarged. And it will say LDH on here, but this sounds like it's more global cardiomegaly. Okay, so he could have right-sided and left-sided heart failure. We don't know. An echo would give us some more information, right?
So is the creatinine or the BNP alone each to bump him over to immersion? Because
So,
of the signs of
it's not,
organ
he's still
failure?
under urgent, unless his troponin comes back elevated. Okay? that would bump him into the hypertensive emergency.
So that.
Or ST elevation on his EKG.
So it has to be like, something that's happening to the baby.
Correct. Yes. Yeah. So this could happen, maybe he's in an emergency right now, he goes up to the floor and gets chest pain. He's gonna pop over to the emergency, right? So you're continually assessing these patients. But a chest pain is a sign of ischemia to the heart, which is a sign of emergency, right? So he would pop over to the emergency.
So he's in urgency until he does further tests as well, if the tests
Yeah.
indicate more.
Okay, so you're learning more, you get little pieces of information. When he comes in, he's swarmed with lab, actually the nurse is getting the labs, it's the IVs going in, it's going right away, you're getting these back real quickly. The 12 days done right away. He's not within the 5 minutes because he's not having chest pain, but as soon as the nurse gets that blood pressure, you're pressing a little button on the wall that says EKG. Your analysis, was that on there? So what can we look at in the EA that will give us information? Protein. Are we spilling protein? So typically, the kidneys are functioning well and filtering like they should be. You're not going to see protein spilling into your urine. So that's something else we could look at. It's another little piece of information. All right. So we looked at all the clinical data. What would you say is the pathophysiology of problems in your own words? How you're giving reports. Let's say this happened right at your change of shift, and another nurse comes in. What might you say to the nurse that's taking over care of this patient? Anyone want to summarize it? You did a nice job. You want to summarize it kind of?
Me?
Yeah.
Oh, jeez.
So let's go.
So just tell what he did, what happened? Brian, 51-year-old male, presented with a headache unrelieved by any analgesics. History, smoked, or I'd give the smoking history. And then I'd give the vital signs. Blood pressure is 230/128. Hypertension, urgency, not showing any organ failure at this time. Elevated BNP. I guess moving up to the floor and trying to get blood pressure down with oral BP meds.
Okay. And I throw in there the cardiomegaly with the
Cardiomegaly with the
Excellent
X-ray.
job. Good job. And then you know, let them know where the IV site is and what the EKG should. All right. So we kind of talked about these already. The 12-week EKG, we mentioned signs of ischemia and injury. If ischemia is occurring, what might you see on the 12-week? Just ischemia. ST depression. Could see also something with the T-wave. And let's say this patient is having a transmural full thickness MI. What are you going to see in the ST segment? Then it's going to be elevated, a stemming. Okay, so that's a sign, ST elevation MI is a sign of a full thickness MI. What we call transmural. All right. Okay, so we get an order. In addition to all these labs, we do get an order. So for some reason, they do want to go ahead, we just say, we're going to, I have this in here just to practice this. Well, they allow 20 milligrams IV push every 10 minutes. So for this guy, he is under the urgency category. Most likely they will be giving him
Oral.
Oral. But we're going to say, let's say he wants just, okay? So we're going to give him labetalol. We have an order for that. 20 milligrams IV push every 10 minutes. A maximum of 300 milligrams. So they can go up pretty high. Of course, whether they tolerate that much labetalol is another question. I'm sorry.
Can you just go back a little bit about what we find in the EKG?
So the watching for are signs of injury or ischemia to the heart muscle. Signs of ischemia to the heart muscle. So the heart's just crying out saying, hey, I'm not getting adequate oxygen. Would be ST depression and T-wave inversion. You can see T-wave inversion with either ischemia or injury. Injury is where you have actual damage to the heart muscle, so that's MI, a heart attack. And the heart releases that troponin, an enzyme. And that T-wave conversion could possibly be and ST elevation. Okay? So you can have an ST elevation MI or a non-ST elevation MI. You don't see it on the EKG, but the troponin's elevated. Okay?
Would you see the T-wave inversion with an NSTEMI?
You could.
You could, okay, but not necessarily.
All right, so let's talk about some drugs and some dosage power. All right. All right, so we get this order for labetalol, okay? This is what it looks like when you pull it out of the Pyxis. You're gonna notice the concentration. It's a multi-dose vial, which it says right up here, there's 20 mils in this vial. If you drop this whole vial and give it to a patient, they're gonna die. So that's important to know, okay? You look at the vial, you read the vial, okay? You notice things like multiple doses, okay? 100 milligrams per 20 ml. We bring a multi-dose vial to the bedside sometimes because we're going to be given multiple doses to get to the target, right? But you're not drawing the whole thing up and down. And this is so we have an order for 20 milligrams IV PIV push every 10 minutes. We can go to a maximum of 300 milligrams with a goal. Let's say we have a goal blood pressure of so what did we say the initial blood pressure was?
230.
Okay, so I want somebody to take, so our goal is to get the blood pressure down to, we're gonna lower it by 25%, okay? That's the goal. So this guy has now kicked over into emergency just so we can work with these strokes, okay? So, we're gonna decrease it by 25%. Yes, we're just saying just for, he's kicked over to emergency. All right. So his beginning blood pressure was 230 over 128, okay? And we are going to decrease his mean arterial pressure by 25%. So what is mean arterial pressure? So it's diastolic plus 1/3 of systolic minus diastolic. Systolic is 230, and and his diastolic is 128. Okay?
That's Jillian.
So when I subtract that, I get,
What?
She plug her phone and charge it.
what do I get? 230 minus
Tell me if it works.
128. Yeah, 102. So this is called the pulse pressure. Okay, his diastolic is 128.
Gotcha.
128 plus 102, we're going to divide that by 3.
I'm sorry, question. Are you gonna want us to calculate this on the exam? I'm just
You're
wondering, so
typically
like,
given the mean arterial pressure,
Okay.
but you should know what it involves,
Okay.
that it is a component of blood pressure.
Okay.
If you get that number, what does it mean? If you're working in critical care, I know some of you are interested in going into critical care, we treat to the mean arterial pressure and not really the systolic or the diastolic. So we're looking at, if your mean arterial pressure is less than 50, there's a risk you're not using your brain, you're suffering from confusion, or changes. If it's really, really high, which it could be in this situation, greater than 100 would be considered like critically high. Okay, so if this person's mean arterial pressure is, let's see, so if we calculate this,
162.
162. Okay, so the mean arterial pressure is 162. All right, so that's high. A normal mean arterial pressure is 70 to 100. Okay. All right. Right
So
then,
when you said when the map is low, we are concerned with it not like getting to the brain. What about when it's high like that?
when it's high like that, you have increased incidence of arterial damage, right?
Okay.
You're damaging your arterial vessels. Things like atherosclerosis are going to be common, right? Hypertension, the risk of stroke is all going to be high with elevated mean arterial pressure. All right. So we are bringing in mean arterial pressure because we're trying to get that down 25%. Okay.
I'm sorry, and normal is 50, no, 70 to 100?
Yes.
All right.
All right, so we have labetalol. And if you look up labetalol, it tells you what is important to know about labetalol. When you're looking up your drugs, what are things you're looking for? You're going to be getting thickness. Yeah, how fast you get over. Okay, that's important. And do we give it diluted, undiluted, right? So we find out that we can give labetalol undiluted. It comes in 5 milligrams per ml, and we're going to give it over 2 minutes. Okay? Yeah, we'll talk. All right. So we have 5 milligrams per ml. How many mLs are we going to draw up? 4. 4 mLs. Okay? So we can do that in our head. We're going to do it a couple times in our head, 3 times in our head, to make sure we're not making a mistake, right? All right. Labetalol. What class of drug is labetalol? So it is a beta blocker, and it has actually several qualities, and it affects beta 1 and beta 2 cells. So what are we asking this guy? We know he's a smoker. So does he have a history of, right? Because it affects beta 2 cells as well as beta 1 cells, it can cause bronchospasm. So that's something that we're asking before we do it. This labetalol is also an alpha-1, it's also this alpha-1 blockade, so it has a vasodilatory effect as well. Okay? So it's going to help reduce vascular resistance. All right, so we have 4 mLs. We pulled it up. We have 20 milligrams in 4 mLs, and we're going to give it over 2 minutes. So how many, if you're giving 20 milligrams over 2 minutes, what's going to be your concentration per minute? give 20 milligrams over 2 minutes.
So it's 10 milligrams.
We're giving 10 milligrams over a minute, and then how many milligrams over 30 seconds? 5 milligrams over 30 seconds. Okay. So we're giving it nice and slow. So you will see nurses, I see nurses often draw these drugs up and they push it right in. Okay. We can have, especially with a drug like this, significant problems. We can have hypertension shock, we can have all kinds of side effects from that. You can even have heart block in some patients. Severe hypotension, syncope, or heart block. All right. So that's our label. Okay. Which of these syringes am I going to draw that 4 ml up in? I have
The 5.
50 ml syringe, a 30, a 20, a 10, a 5, a 3, and a 5. I'm going to grab the 5 ml, right? So I can see the increments really clearly, and I can get it. All right, so let's say the patient, so Brian's blood pressure comes down a little bit, but it's not at the goal blood pressure, the actual pressure that we need to be at. So the doctor then orders an IV drip. And you can give a Labetalol IV drip. I'm going to bring in another drug to talk about. So let's say we're going to give nitroprusside, sodium nitroprusside. And we're going to do a continuous infusion, okay? So this person would be in the ICU, and they would be, you wouldn't be getting this outside of the ED or ICU, okay, where you can monitor them closely. You have one, possibly 2 patients that you're monitoring. We look up sodium nitroprusside, and we learn that the concentration in our facility is taking 50 milligrams of nitroprusside, and diluting it at 100 ml, and we want to administer it at a rate of 0.3 mics per kilogram per minute. That's the initial beginning dose, okay? We could give a much higher dose, but this is where we're going to start. And this is a drug that we titrate up, okay? So we titrate up according to whatever the order says. It could be systolic pressure, or it could be the arterial pressure, okay? So how often are we checking this person's blood pressure? So initially, we're going to be cycling it frequently, right? Like every couple of minutes, like a minute seems like a long time when you have a patient who gets these drugs too. Okay? So you're doing frequent vitals. If you're in an ICU setting, they might even put like an arterial line in this patient so you have a constant waveform of blood pressure. Have invasive arterial line. So we want to, based on this information, we want to calculate a flow rate. Okay? Are we calculating drops per minute or milliliters per hour? Minutes per hour. So this would never be by gravity. You're always on a pump or this strap. All right. So nitrite, by the way, is a potent vasodilator, and it's going to, it has an extremely short half-life, and it's going to work very, very quickly, like immediately. Like you give it, you see an effect. Okay? And it also affects both veins and arteries. So the venodilator and the vasodilator, veins and arteries. And also, so it's going to affect your periphery, so you're going to see that blood pressure come down nicely. And if you look it up, you're going to find that it works by releasing nitrous oxide, which activates, granulates, cyclates, and vascular stimulus. Okay? What you need to know about it is that it's a venodilator. In addition to lowering blood pressure rapidly, it's going to reduce workload on the heart, myocardial oxygen demand, and cardiac work.
Both.
It's gonna affect both. So the venal side, we're gonna see a decrease in free load. And then it's gonna widen the vessels off the heart, and you're gonna see a decrease in free load. It's gonna affect both free load and afterload. So you see how that takes a hold of the nerve? This is recommended to be given in D5W.
What is up, guys? It's your baby.
It's on its own pump with its own primary tubing. And it's also, you notice how the vial is brown? It's extremely photosensitive, so light can degrade the chemical composition of nitrogen. So not only is it in brown, you know how with nitroglycerin, you see the same thing? The bag is wrapped in it's wrapped in a brown paper bag over it. This is actually a foil over it because it's even more photosensitive than nitroglycerin. Okay?
Over the actual bag?
Foil, that's a foil wrap.
Okay.
Okay. All right, so let's do dosage count. After tubing, actually don't have to tubing. So a typical infusion rate is 0.3 to 8 micrograms per kilogram per minute. So I want you to try to calculate this on your paper first, and then we're going to go through the calculation. Many of you have problems with mics per kilogram per minute on this exam. And I want to make sure you try it first, see if you get it right, and then we'll go through it. Okay? So what did we say this way? Yes, that's correct. 275 pounds. What is it? 275 pounds. So we're doing milliliter per hour flow rate. I used dimensional analysis, everybody. Some of you I wrote out the entire thing the way I would do if I were to write out each step with dimensional analysis, okay? I'm looking for milliliters per hour, so always start with what are you looking for? And then your equal sign. I know for me, if I'm using DA, milliliters has to be in the numerator, and I have, what do I have for milliliters? I have 100 ml bag, I have 50 milligrams in that. Okay? I don't have anything else with milligrams, but I do have micrograms, so I know I need to put in my conversion. So my conversion is right here. There's 1 milligram and 1,000 micrograms. I know milligrams goes on the top because it's down here, okay? And I'm eventually going to want to cancel that out. Then I have my dose, which is 0.3 micrograms per kilogram. Then my kilogram weight goes here, and it's per minute, not per hour, per minute. And then I have my conversion for time, 60 minutes per hour. I'm going to cancel zeros top to bottom. Okay, and I end up with 1 times 1 times 0.3 times 125 times 6, divided by 50 times 1. Okay, so I will then get a flow rate. Okay, so what did y'all get for your milliliter per hour flow rate? 25 milliliters is correct. Okay, so some of you may have, like, maybe you transferred your micrograms to milligrams right away, but that's all fine. If you didn't get this, and I know many of you didn't get the 2 mics per kilogram per minute on that last exam. Go back to TA with the method, go back to state Medicaid with the method that you are using, and do some ADAs where it will help you set up your ratios and the bullshit appropriate to that method. Alright? Any questions about the DA? Alright, so just one little fun fact at the end before Professor Silva starts. So, giraffe's heart is about 25 pounds, and it has to perfuse its brain, and it has to perfuse all the organs of its body. It's about 7 feet between its heart and its head. So it has to sustain a blood pressure of like 300 over 200 in order to defy gravity and get to perfuse the brain. So for a human, that would tell us, right? If we have a pressure of 300 over 200, but giraffes have to have that in order to perfuse the brain. They have, they don't die or faint from high blood pressure due to several adaptations to their blood vessels, as well as a tight wrap of connective tissue around their legs that prevents blood from pooling in their legs. Kind of interesting how we have different adaptations depending on how we're created. All right, so that's kind of, if you have any questions about this content, feel free to meet with me via Zoom or in my office. I'd be glad to sit down with any of you. No, I don't have any hot slides for this week. So there are 5 questions on exam 4 on this, and 2 questions on the final. Okay? So just focus on the differences between urgency and emergency and medications. Okay? And you'll have, your dosage calc will have some mics per kilogram per minute. You want to make sure you know how this